Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine. Welcome to Moving Medicine, a podcast by the American Medical Association. In this episode, AMA President Dr. Bobby Mukkamala is joined by experts to discuss key state-level issues AMA Advocacy is working to address. Experts include 3 senior attorneys with the AMA Advocacy Resource Center, Daniel Blaney-Cohn, Emily Carroll, and Kim Horvath. Here's Dr. Mukkamala.
Hello, and thank you for joining us this afternoon. I'm Dr. Bobby Mukkamala, President of the American Medical Association and an otolaryngologist in private practice here in Flint, Michigan. It is great to be with you all today for this important discussion about the issues physicians should be paying attention to as state legislative sessions are underway this year. So with so much attention in 2025, while so much of it is being paid at the health policy changes at the federal level, it's the issues unfolding in the states, such as scope of practice, prior authorization reforms, physician burnout and wellness, that are among the most important issues physicians and patients are facing. And that's why they remain among the AMA's top advocacy priorities. But with each new year, while there are endless challenges, there are also opportunities to engage in solutions that can help us create a better health system. And that will be the focus of our conversation today. The AMA has a number of tools, resources, and support to help state medical associations and national medical specialty societies confront these challenges and improve patient care in their home states. We'll be discussing the trends we are seeing in states across the country and giving you an idea of what effective state-level advocacy looks like. To help us, we have 3 experts from the AMA's Advocacy Resource Center, the ARC, which is the hub where we collaborate closely with national, state, and specialty societies to influence laws and regulations to best support physicians and patients and help shape the healthcare policy landscape. I'd like to welcome 3 senior attorneys from the ARC, Emily Carroll, Kim Horvath, and Daniel Blaney-Cohn, who specialize in different healthcare policy issues for the AMA. And I will just add that having experts in their work like these 3 let us as doctors stick to our jobs, our passions, to take care of our patients. We do what we love, and these folks do what they love, which is improving healthcare in this country. So thanks, guys. They're going to provide us with an inside look at these issues and the states where progress is being made. I'd like to start by asking each of you to talk about the trends you're seeing across the country on the key issues that we're talking about today: prior authorization, scope of practice, and physician wellness. We're about halfway through some state legislative sessions, while others are almost done and a couple are just getting started. So how are state legislators addressing these issues now? And are there any big surprises or changes from how legislators may have been looking at these issues a year ago? Why don't we start with you, Kim?
Thanks, Dr. Mukkamala, and thank you for the pleasure to be here today and talk to physicians and healthcare leaders across the country on these important issues. We wanted to start with a little bit of an overview of kind of where we are. Most of the states are going to wrap up their sessions by the end of May. About a dozen more will finish up in June. And then several states do kind of continue over the year to have sessions. So right now is really crunch time in a lot of the states. And I'll also think it's important for everybody out there to understand that with the exception of a couple of states, we're at the start of a 2-year legislative cycle. And what this means for what we'll be talking about today is that if legislation has reached a certain point in the legislative process this year, in many states, that legislation will carry over to the 2026 legislative session. And I think it's also important for everybody to note that the procedural aspects and everything vary so much by state. And so we really rely on those at the state level and the state medical societies to help us kind of best understand all of that and those unique features in their states. So to talk about scope of practice specifically, I'll start there. This is an issue that continues to be one that state lawmakers want to address. It comes back year after year. And I think it's really unique among the other topics that we're going to talk about today, prior authorization and physician wellness, in that our focus is really defeating bills. So that puts us in a little bit of a unique position. And we continue to oppose the inappropriate scope expansions, including legislation that would allow physician assistants, nurse anesthetists, nurse midwives, nurse practitioners, and such to practice without any physician supervision or collaboration or oversight whatsoever. So we continue to try to oppose those bills and work to oppose those bills. We also oppose legislation and work very hard to oppose legislation focused on pharmacists, and specifically legislation that would allow pharmacists to diagnose patients based on the results of a test and then prescribe medications to patients based solely on the results of that test without any sort of physical examination or any other information about that patient. We're also working very hard at the state level and seeing a lot of bills focus on naturopaths, including bills that would allow naturopaths to be licensed in a state, as well as the ability to prescribe medications, including controlled substances in some states. And then finally, we're focused on optometrists who continue to look to the ability to perform surgery in states, and then psychologists prescribing legislation as well. And I think across the states, we often see similar bill language because the non-physician advocacy organizations kind of work to kind of have similar language in states. So we are able to see that legislation or that language pretty clearly. But I think the biggest change we're seeing this year is the volume. This includes legislation that was defeated in previous years that comes back again, year after year, right? We're also seeing that in those states where they may have expanded a particular non-physician scope of practice in prior years, we often see that non-physician come back in future years looking for further scope expansions. And we're also seeing other non-physicians will see that a state, that some non-physician was able to expand their scope in that state, and then they come in, other non-physicians come in with their own legislation. So we are seeing a lot of bills this year and tracking a lot of bills across the country on scope.
Thanks, Kim. Emily, there's a couple of other ones, prior authorization and physician wellness. You want to give us an update?
Prior authorization, absolutely. So in prior authorization this year, I've seen like really a broad range of bills in terms of their scope. We've seen some really big comprehensive prior authorization bills that target a number of issues. And then we're seeing a lot of smaller bills that target maybe one aspect of prior authorization. And those may be part of a state medical association's kind of multi-year plan to implement prior authorization reform. But I think generally a couple of, kind of themes we're seeing across the board. There seems to be a recognition that we have to address the delays in prior authorization. The AMA would say 24 hours for urgent care and 48 hours for non-urgent care is sort of the gold standard. We also agree that, and we're seeing a lot of movement towards automation of prior authorization. There's new federal standards for both the drugs and medical services benefits, and we really support aligning state requirements around automation with those. I think we would point out that automation alone is not a whole solution in and of itself, but it certainly is part of the prior authorization solution. There also seems to be a lot of momentum around reducing the volume of prior authorization. I think this is what we talk about a lot, right? Like the volume, everything is being required to be prior authorized. And so some of the solutions that we're seeing include exclusions for certain types of services. So like, excluding treatment for substance use disorders or cancer care. We see some states remove prior authorization for primary care or for generic medications. We're also seeing an effort to really reduce repeat prior authorizations, especially for patients who have chronic conditions or long-term conditions so that they're not going back to their physician to get prior authorization for the same treatment for the same condition multiple times a year. And then we continue to see a lot of gold carding proposals, which are that idea that if you have a high rate of approvals from an insurer on a particular service or a particular group of services, maybe you shouldn't have to be doing prior authorization repeatedly for those services. So you should get a gold card or an exemption for that. And then we're also seeing a lot of states adopt requirements and consider requirements around the qualification of the reviewer on the plan side. So we would say from the AMA's perspective, certainly that reviewer on the plan side should be a physician of the same specialty, licensed in the same state, and have experience treating that physician in order to be making that medical necessity determination, because really that is the practice of medicine. So we're seeing a lot of states kind of toy with those qualifications and kind of tighten up who can be making those decisions. We're seeing a lot of efforts around data collection. So kind of either having insurers post on their website statistics around their prior authorization approvals and denials and wait times and things like that. And then we're seeing a lot of states kind of move away from even just having the individual payers posted on their website and have that data reported to the insurance commissioner, so we can see kind of trends and really make more targeted reforms. I think a lot of lawmakers are interested in getting their hands on that data and really seeing how they can make specific improvements that relate to their state populations. We're seeing a lot of continuity of care. So that idea sort of as you switch plans, maybe you don't have to start all over on a prior authorization, have that 90-day period where you can stay on your medication and not lose function or not lose health as a result of having to do a new prior authorization. And then certainly a lot of bills around transparency. So transparency on reasons for denials, transparency for the appeals processes, transparency on the criteria that's used to make these determinations. So yeah, a lot of movement around that level of transparency. And then finally, kind of something a little bit new. Last year, we saw California enact a bill related to the payer use of AI in prior authorization determinations or medical necessity determinations, and making sure that if an AI tool was recommending a denial, that a physician was in the loop, that a physician was the one ultimately making that denial rather than the AI tool. And this year we're seeing a lot of states kind of glom onto that idea and start introducing bills that would keep a physician in the loop when it comes to AI tool decisions. So we're certainly supportive of that. And I think we're going to see a lot more activity kind of in that AI space.
Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/moving medicine.
No, thanks for that answer. I mean, prior author, you guys know, I mean, I've had a recent diagnosis of this brain cancer, and the medication that I happen to be recommended to take literally costs $900 per day. And so I completely get why prior authorization is required for something that's, 200 plus thousand. The downside of that is it's prior authorization every 14 days for the rest of my life for years to come. And so there's right sizing of prior authorization in multiple aspects. I think the number of days that we get authorized for, but that same sort of criteria for somebody with insulin dependency that's going to need insulin for the rest of their life, just like I need this pill, when it's not $200 a day, or sorry, $900 a day, there's a right sizing that needs to be done. So thank you for that update.
Your important point.
Daniel, you want to talk to us about physician wellness and what's up that way?
Sure. Thank you, Dr. Mukkamala. Unlike the 94 different aspects of, scope of practice and, and prior authorization and payer issues, what we're trying to do with physician wellness in the legislative standpoint, on advocacy standpoint, is really focused on a couple, just a couple of key things. One is we want to remove stigmatizing and inappropriate questions on physician licensing applications and credentialing applications, and anywhere else that a physician or really any healthcare professional has to fill out. And what I mean by that is on these applications, physicians and others are asked to disclose if they've ever had any treatment for a mental health issue, if they've ever had any treatment for a substance use disorder, when there is no current impairment. And that's the distinction we try to make in our advocacy. We want to ensure that there is safe practice. So if there is a current impairment, that should be disclosed to a hospital, health system, or licensing board. But if there is no current impairment, we want to encourage physicians to not have the fear that getting treatment will have to be disclosed. And so what we're doing on an advocacy front is one, working with regulatory boards, which we'll talk about in a little while, to change the questions, working with them directly, and also trying to enact state legislation prohibiting these types of questions. And that type of legislation we've only started doing that for a couple of years now. And we really want to give a shout out to the Medical Society of Virginia for being the first one to do it. And one of the trends we see is other medical societies and other state legislatures saying, we want to do that too, because we care about our workforce. We don't want our physicians to be unsafe. And in fact, we want our physicians to be well. We don't want them to fear getting treatment. And so the legislative and regulatory trends that we're seeing, everybody's going in the right direction. Nobody is fighting against us. And so it's a question of awareness. There are a couple of years ago, there were only about 20 medical boards that were free of where the licensing applications were free of stigmatizing language. We're now at about 34. A couple of years ago, there were only about 50 or 60 hospitals and health systems where their credentialing applications were free of stigmatizing language. Now we're on our way close to 600. And so the trends are only going one way. And this is the kind of thing that myself, Emily, and Kim, we work directly with states to try to provide these best practices directly so states can implement them.
Thanks, Daniel. And yeah, absolutely. I think it's one of those things that we're going in the right direction. The faster we get there, the less physician burnout we're going to have, right? I mean, if physicians have to deal with this measurement that's based on old data, it's just going to make one more thing that would make us leave our profession more earlier, and just consequences, worse patient care. I mean, we're already challenged by that. So thank you for that. I'm just going to jump to a comment about prior authorization that we've already had in the question box. And it said, presuming that we're aware about the adverse outcomes associated with prior authorization. And I'll just share with this person that, yeah, I mean, when I gave testimony in Michigan about prior authorization being a problem, I took with me a patient that had stage 1 tonsil cancer before we asked for the PET scan that was required to figure out what treatment was needed. While waiting 3 weeks for the PET scan, the patient went from stage 1 tonsil cancer to stage 2 tonsil cancer. Right, developed a metastatic node. And I took that patient with me, and it was amazing how effective just the story of an individual patient was relative to national statistics in convincing the people at the Senate, the hearing, that, wow, yeah, this is a problem. So absolutely, we share that information with our lawmakers. Just the question in general about our interaction. So how does your team work with the State Medical Association to urge state legislators to make crucial reforms in these areas? So how does the AMA fit in with the Medical Association when the person that we're addressing is the state legislator? What is that interaction like? Emily, you want to tell us?
Sure, and I know Kim and Daniel have more to add, but I'll kind of start by saying that we really try and be a resource for the medical associations, and that may look a little bit different in every state. The medical associations are the ones who know the politics in the states, the legislative strategy, but we can offer them sort of a broad perspective, what other states have done, what's maybe happening federally and nationally that they can sort of build on. I'll give you just a quick example on prior authorization. Obviously, there's so much constant activity in the states and federally that it'd be really hard for one state to kind of keep up on sort of that national activity and to keep up on the trends or successes that other states have had. So I can provide them with information on prior authorization bills that have passed in other states, how they were framed, what groups were engaged in supportive, and what tactics the plans used to fight those bills. And we try and develop the resources so they have sort of turnkey solutions when they're having these conversations. For example, last year, we developed a new issue brief on prior authorization on how states can sort of use the new federal rules on prior authorization to promote reform in their states, because we knew that states were hearing from lawmakers and the plans that there was no more need for state legislation on prior authorization because the rules at the federal level had fixed it. And so we developed an issue brief that states were able to quickly use and say, oh, hey, that's not true. We can build on our federal wins, but state legislation is really important, and here's why. So kind of resources like that to help them in their efforts. And then we often engage directly on legislation if it's going to work in a particular state, if that's helpful to them. So we write letters of support for legislation. We can testify. We submit testimony. And then we always are reviewing bills and tracking bills and providing input to the medical associations as they go through their sessions. I'm sure Kim and Daniel have things that I've missed.
Sure. Daniel, you want to give us your impression about the intersection between us, state medical societies, and state legislators?
Sure. Let me give you an example. Colorado this year. So we have a series of best practices in an issue brief, but the series of best practices that highlights certain pieces of other states that have enacted laws to prohibit these types of licensing questions that require disclosure of past treatment or diagnosis of mental health or substance use disorder. And so we talk with medical societies and specialty societies about the information in the issue brief. Well, in Colorado, the state chapter of the Family Physicians and the State Medical Society, the State Emergency Medicine chapter, and the State Psychiatric Society all got together and using that issue brief, went ahead and decided we need to amend state law to go ahead and ensure that the licensing applications throughout the regulatory boards are free of stigmatizing questions. And so the AMA worked directly with our partners in the state, in Colorado, to produce an amendment. And that was, there's a legislative champion in Colorado, a couple of legislative champions. And then working together, there was a bill that was introduced. And part of the aspects of that is that we also identified physician champions within the state of Colorado to develop testimony. And so they testified at a hearing. We identified a medical student who wants to be able to ensure that if she seeks treatment or her colleagues seek treatment, they won't fear disclosure and potential professional repercussions for seeking care for a mental health issue. And so all of that combined together, and that bill passed the House. It's awaiting hearing in the Senate, and we'll take the same approach. Negotiating behind the scenes with people who might have some concerns, and then testifying. The AMA was also testified at that hearing, and will testify directly before the legislature on the benefits of that legislation, provide any additional information, data, what have you, about what's happening, and then also provide Colorado, and this was an important point in Colorado. We've had so much success in states in doing this. Colorado doesn't want to be left behind. They want to be known as a place where it's safe to practice medicine. And so that's been an important point. So everything coming together, it's one small microcosm in Colorado, how AMA resources work behind the scenes, partnership with our state and specialty societies, and really relying on medical student and physician advocacy has been successful so far in the House, and we hope it's successful in the Senate, and the governor will eventually sign it.
Thanks, Daniel. And Kim, I mean, it's pretty clear that scope of practice is such a critical local level thing that varies from capital to capital. So what are your comments or thoughts about the teamwork between what AMA can do to help the state medical society influence the legislators' process on looking at scope of practice stuff?
Yeah. So yes, scope is a priority for a lot of the state medical associations, just as it is for the AMA. So they are all over it. And as Emily and Daniel both mentioned, we provide a ton of resources, write letters, draft testimony, provide best practices and other specific state solutions, reviewing legislation and providing some, recommended amendments or language that they might work on, as well as talking points that they might be able to use to refute arguments that are made by proponents, because we've often heard those same arguments in other states. One of the things I think is particularly unique about the scope of practice space is the work that we do through the scope of practice partnership. And this is something that began back in 2007. It's comprised of more than 110 medical associations, including the state medical associations, including national specialty societies, the AMA and the American Osteopathic Association. And really our goal of that is to be able to provide additional resources, funding, as well as data and other type of in-kind resources to support our colleagues at the state level. And it is a very actionable way in which we do get involved at the state level and really help our colleagues get things across the finish line.
Thanks, Kim. And thank you to our panelists for joining us today and helping us take better care of our patients.
Don't miss part 2 of this conversation. Subscribe to Moving Medicine today. Thanks for listening. Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine.